Hello, and welcome to FirstCallID Approach to Fever of Unknown Origin. I'm Paul Bunce, and I'm an ID physician. Over the next 15 minutes or so, I'll walk you through how I approach fever of unknown origin as an ID consultant, what to look for, how to organize your thinking, and how to keep the process efficient. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultation in general. This video builds upon that, but also focuses on the unique challenges of assessing patients with fever of unknown origin. And as always, this is for educational purposes only. Use current guidelines and your own judgment in clinical practice. So before we get started, we'll start with some basics. The definition of fever of unknown origin, at least classically, is a temperature greater than 38.3 degrees Celsius for greater than 3 weeks, with no diagnosis after 3 days in hospital and at least 3 outpatient visits. The idea is that quick, self-limited fevers will have resolved, and you'll probably rule out some of the common things with your routine investigations. In reality, most referrals to ID for, quote, FUO don't quite fit these criteria perfectly. And that's okay, because the framework that we're going to discuss is still helpful to assess patients with unexplained persistent fevers. Now, there are subtypes that have been described since the initial classic FUO, and that includes nosocomial, neutropenic, and HIV-associated fevers, each with its own sort of short list of causes. And the last point to help manage our own and our patients' expectations is to recognize that most cases of fever of unknown origin aren't solved in the first assessment, and it often takes a bit of time and a structured approach to get to the bottom of things. And just a reminder, this is not a fever. You need a thermometer to tell if someone has a fever. Now, I like to keep the causes of FUO into some large buckets or categories to help organize things. From an infectious perspective, things to consider would include tuberculosis, occult abscesses, infective endocarditis, post-op infections or complications, and some viral infections like HIV, CMV, or EBV. Although CMV and EBV will often have positive serology indicating chronic infection, and that's almost never the cause of the patient's current complaints or fevers. Inflammatory causes, such as temporal arteritis or giant cell arteritis, adult onset still disease, vasculitis and sarcoidosis, and occasionally inflammatory bowel disease. Cancers can be a cause of unexplained fevers, commonly hematologic malignancies like lymphoma, and occasionally some solid tumors as well. And then there's a grab bag of other causes to consider, such as drug fever, venous thromboembolic disease, endocrine causes such as hyperthyroidism or adrenal insufficiency, some familial or genetic causes, and occasionally factitious causes. Here are the key points to outline or structure my assessment in patients with fever of unknown origin. I want to clarify the details of the fever, the onset, duration, and pattern. Also, any associated symptoms that have been going on alongside the fever. I'll take a detailed medical history in terms of comorbidities, any medication use, substance use, a detailed exposure history and epidemiologic history. Our physical examination will be a general examination, but also focusing on any abnormalities that we might have detected on the history or other investigations. The approach to investigations is a structured layer by layer assessment. Rather than a shotgun approach, we try to be stepwise and organized as we go through things. And from all of this, we'll form our initial impression and outline our plan. And as I said, that usually is a stepwise plan for further reassessments. So in terms of the fever, when was it first documented? Was there any potential trigger, travel, new medications, any exposures, procedures? If there's been any treatments trialed, such as antibiotics or other anti-inflammatories, did they make a difference? And is there any prior history of febrile episodes in the past, either explained or unexplained? There's a long story of matching fever patterns to particular diagnoses. Okay, but the truth is that the pattern alone rarely gives you the answer or the clear diagnosis. But knowing them can give you a nudge in the right direction. It's also helpful just to describe the pattern of fever that you're encountering in a given patient. And so these are listed here. First is intermittent fever, where a patient will have a phase or phases where the temperature is greater than 38 degrees Celsius, but also periods where they're afebrile. Remittent fever is a condition where you're a situation where the fever or the temperature is persistently greater than 38 degrees Celsius, but varies by more than 1 degree. Continuous fever is similar, where there's a sustained temperature over 38 degrees Celsius, but much less variation in the temperature. These two types of sustained or continuous fever are often attributed to things like typhoid fever, infective endocarditis, or even drug fever. Next is undulant fever, where you'll see a phase where the temperature is persistently above 38 degrees, but gradually over the course of days will decline to a phase where they're afebrile and then recur again afterwards. This pattern is classically associated with brucellosis. And lastly, there are many types or forms or patterns of relapsing fever. And these are defined by the cycle or periodicity, which I've listed below. And again, the period that's noted is often linked to particular diagnoses. Several of them are linked to different forms of malaria. The one I wanted to point out specifically is the Pell-Epstein fever, which is classically associated with lymphomas, where the patient will have sustained fever over the course of several days or up to a week, and then a phase where they're afebrile, and then the pattern will recur again afterwards. Again, these are not diagnostic, but helpful clues to guide us in the right direction. And when we assess associated symptoms, it's really a complete review of systems. And this is where a lot of our early clues will come from. So we'll ask about constitutional symptoms, night sweats, unintentional weight loss, any skin changes or rashes that may be transient in nature, musculoskeletal complaints or symptoms, neurologic symptoms, headache, neurologic signs or symptoms, or deficits, cardiac symptoms such as chest pain or symptoms of heart failure, any vascular symptoms, gastrointestinal symptoms like nausea, vomiting, diarrhea, constipation, abdominal pain. We'll ask about cough, sputum production, chest pain, shortness of breath, screen for genitourinary symptoms, as well as any lymphadenopathy or just noticing any new lumps or bumps. We'll review their medical history, really focusing on the presence of any prior history or diagnosis of malignancy, autoimmune disease, or chronic infections. We want to know if they've had any new medications, and also review any non-prescription medications. We'll take a detailed substance use history, including prior injection drug use, that may expose them to other bloodborne pathogens. We'll also include a detailed exposure history and appreciation of the patient's epidemiology. And it's not limited to, but it would include things like occupation, different types of animal exposures, activities and hobbies, any travel, any sick contacts, and if they were born abroad, where were they born? One of my colleagues, when assessing patients with unexplained fevers, will ask, have you ever seen an animal, or have you even seen a cow, just to get a sense of any potential zoonotic infections or zoonotic exposures. Our physical examination will be complete, a head-to-toe examination, but also focusing specifically on things like lymphadenopathy, joints, dermatologic exam, upper cortical examination, as well as examining for heart failure and stigmata of infective endocarditis. If a patient mentioned that they might have had a rash in the past, ask if they have photos of it. They often will have photos on their phone that can help give you a sense of something that might be transient in nature. So there is a huge menu of tests that you can order when assessing patients with fever of unexplained origin. The key is to follow a structured and organized approach. You might want to add or omit some specific tests at each stage based on your suspicion of particular causes or the clinical presentation, but you want to keep track of what you're ordering and chase any abnormalities or any abnormal tests with further specific or focused evaluation. Here I'm outlining one example of a tiered approach to the investigations of a patient with FUO. This is based on what I was taught in my training, and I find it useful. I think the key thing is to have a structured approach and to work through things methodically. And I'll often print off a copy of this to keep tabs of what's been sent, what's pending, and also what's abnormal to focus my next step of evaluation. In terms of the basic evaluation, so basic blood work, CBC with a differential and a blood film. Basic inflammatory markers, including a ferritin. Urinalysis, blood and urine cultures, a chest x-ray, some basic autoantibodies, and some targeted tests if my suspicion's high. If that's unrevealing, I have a second layer of testing that'll include an expanded autoimmune panel, mycobacterial cultures, some targeted serologies, more enhanced imaging, like CT of the chest, abdomen, and pelvis, and even pursuing a TEE if I'm suspicious of infective endocarditis. The third tier we rarely get to, and I think you must be much more cautious with this phase because these are more invasive tests, but occasionally you do have some yield to biopsy of the liver, lymph nodes, temporal artery, or bone marrow, even if there's not clear abnormalities on the investigations that point these directions. You might consider endoscopy to screen for certain GI pathologies. I'll mention that laparoscopy was classically described as a sort of third phase or third tier investigation. I think that was predominantly when there was less accurate cross-sectional imaging. And nowadays, this is really reserved for patients without a diagnosis, but where there are findings on abdominal imaging to suggest some type of intra-abdominal pathology. So from all of this, I provide my summary, my impression, and my recommendations. I want to summarize the key aspects of the history and notable findings. I'll give a preliminary list of my differential diagnosis, maybe including a few likely possibilities, but I try to avoid one specific leading or provisional diagnosis just for fear of tunnel vision or premature anchoring. I'll mention any red flags or sinister features that might make me want to accelerate my evaluation. I'll mention whether I want to offer any empiric therapy, either antimicrobial therapy or even anti-inflammatory options, or to hold off and observe. And then I'll provide a clear outline for the next steps, both to guide me when I'm seeing the patient in follow-up, for the referring team so they understand our approach, and for the patient to engage them in the process and help them appreciate that it is sometimes a bit of a process where we have to work through it together. So here again are the key points to our assessment of patients with FUO. Clarifying the details and pattern of fever, a clear review of associated symptoms that sometimes need to be revisited in follow-up visits, medical history, exposure history, and epidemiology, which again, we might get more and more depth in follow-up if we're still without a diagnosis or explanation. Our tiered approach to stepwise investigations, and then a summary for everyone involved. So some additional pearls or tips based on my experience on assessing patients with FUO. The first is, it's very important to follow patients who remain without a clear diagnosis. I think there's always value in following our patients, but even if we don't suspect an infectious cause, it's worth seeing how things progress over time. One, to see how they turn out. And also, sometimes it just takes time for a process to declare itself. And so you want to see where things end up. And maybe the story will change where you might detect something that is infectious in nature. There's a common phrase used by ID doctors, attributed to Willie Sutton, a bank robber, where he was attributed to say, why do you rob banks? He says, because that's where the money is. And we always say, go for the money. And that means if you see any abnormalities on your history, your exam, or on investigations, you should go after that as a potential cause for the fevers. At the same time, it's important to recognize that in some patients, especially when they're clinically stable or not deteriorating, you might want to take a pause and know when to stop digging, because sometimes our invasive tests or investigations can actually cause harm, and you might want to defer them if they're not absolutely needed. The last, to get a bit tongue-in-cheek, but of the cases I've seen, whenever someone says, I think this is going to be still disease, it isn't. Still disease can occur, but it almost always crops up when people have forgotten about it or weren't considering it at the outset. And so just keep in mind that we have to be humble when we're assessing patients with FUO, because we can be surprised. There are many excellent resources or reviews on the topic of FUO. The two I'm going to highlight here. The first is the actual original paper by Petersdorf and Beeson, which described a case series of 100 patients with unexplained fever. This is classic and definitely worth a read if you're going to be or are an ID physician or interested in the topic. The second is a more modern review of the approach to patients with FUO. It's from 2025 in the British Medical Journal. So that's all for now. I'm Dr. Paul Bunce. I want to thank you again for watching the video. Please share any feedback you have about the session or FirstCallID as a whole. And if you like what we're doing, tell a friend. Take care.